Well, good afternoon, and thank you for coming back after lunch. I know when I got back, I was the first one to learn that they removed all the balloons. So they thought a lot of me, but they saved me one. So I'm not going to carry it around the whole time, but if y'all get bored, you can play it like a volleyball and just move it around. It's interesting being the last one to speak on such a boring subject. And I can say this because I've been part of respiratory a long time, and we in the sleep world, and I'm going to show you how long I've been part of respiratory in a second, but we in the sleep world and the respiratory world, we go through a lot of growth, or we go through a lot of different things as everything evolves. And it's really interesting being in it as long as I have now. I haven't practiced yet. I hit the right button. Okay. So it's interesting, my first CPAP I ever set up was what I set up. So if y'all can recognize an IPPB machine, and if you're nodding your head, that tells me something. I won't share it with everybody. But if you are nodding your head, then this was the first CPAP I ever worked on or did anything with. And to those y'all that remember that, remember the days of IPPB, and this is what we did, and we were inhalation therapists. Do y'all remember that? Yeah, and I've been around because I saw the licensure board happen and where respiratory therapists got licensure. I'm anxious to see as we move forward in the sleep industry, how that moves forward in the sleep as well, because I think all that recognition is great. Every time I come to this conference, I enjoy it so much. And I learned something new today. I learned that, when a person passes away, the whole body shuts down, but the last thing that stops working are the eyes because they dilate. Okay, that's a good start. Everybody got it. Everybody got that. That always makes me feel a little bit better. Okay, if I need to explain it, just, forget it. Anyway. What I want to do today is talk a little bit about what goes on behind the scenes. I know I'm the last one to talk today, although you're staying all weekend, so I can talk much longer, but they're probably not. They're saying, speed this up. So, but one of the things that happens is the things that you do in a lab, you go and you test, and you're making sure all of that's done adequately. But sometimes you don't know what happens behind the scenes, what's going on. Everybody wants to get in your business. We just had an election, everybody wanted to get in that business. That's all I'm saying about it. But what I wanted to say is that you have all these government regulations or private payers, and where they always talk about outcomes, what is their main role? To save money, right? To not pay you for what you do. To find an excuse not to pay you. And sometimes I feel it is an excuse. So what I'm trying to do is I want to let you know what you have to do or who all is watching what you do, and you don't even know it. It's kind of like when I go home and my wife said, "Did you do this?" And I'm going, "How in the hell did she know that?" That's kind of embarrassing. So, but I'm going to go through some definitions with you today and some of the rules and where you find them. So the learning objectives today is just kind of understanding some of the rules that regulate sleep. What all's going on? Who's involved in it? Where do we find the regulations for your lab? Sometimes it's through accreditation, and that's excuse me. Okay, it's also really bad to eat and then come and talk. Okay, so excuse me. Okay, we're good. So I'll always hate that. And what type of data should be collected in your lab? Most of this you think you know, but let's see what goes on behind the scenes. The goal today is to ensure that you all know exactly who all's watching what you do. Sometimes you think it's your boss, the patient, or the administrator of the hospital, the physician, and that's it. Let me tell you, that's far from the truth. So OIG. I'm going to go through what the OIG thinks of you all, of what in the sleep industry. Now, they do recognize the importance of this because obviously you've heard all day long about the sleep and the people that are lacking sleep. Robert talked about it, all the people going on and on about how much sleep is involved, how much if you don't get sleep, and how much sometimes the other diagnosis and the comorbidities associated with it, really make a healthcare expense increase. So the OIG is the Office of Inspector General. They're a government regulation group, and they audit and reports on healthcare entities, including sleep facilities such as labs, clinics, as part of the mission to prevent fraud, waste, and abuse within Medicare and Medicaid. Here's a breakdown of the OIG report. So I'm going to show you what happens. In OIG reports, if you ever get really bored, and you would have to be really, really bored to do this, really bored. But every January, February, the OIG puts out a work plan. And they tell you what they're going to look at because they think there's more frequency of fraud and abuse. That means they increase their audits. So what have they looked at in sleep over the past several years? So billing and coding issues. Well, we know sleep facilities sometimes, and by the way, these are the OIG's rules. These are OIG's words. So Medicare frauds. Sleep facilities sometimes bill Medicare for services that are not either medically necessary or not rendered. OIG reports often highlight overbilling, including inappropriate billing for split-night studies or diagnostic studies without proper documentation. They did some audits recently, well, I'll say recently, over the past 2 years, that found that sleep labs were billing for split-night studies, but they're all done in the same night, or they were done in a different night, right? So they used two different codes, right? They did one, you're going to come back. So the split-night study was actually done in one night, but they billed for 2 nights, right? That's a problem. And you think, well, I would never do that. Well, somebody is doing it. I always say that people come to my talks of not the ones doing it because it's safer that way. But anyway, I always think, though, that if you're here, you're learning what's going on in the industry. But this is what's happening, and it's out there, and they can prove it. Improper use of CPT codes. And how hard can that be? In the sleep world, there are only a few CPT codes that you use, right? You all know them. You can just quote them off. In the DemiPost world that I came from as well, there are HCPCS codes, and there are 5,000 plus HCPCS codes. So, but with only a few CPT codes, usually if you code it wrong, it can happen. But usually if you code it wrong, it's just a mistake. It's not you're doing it intentionally. Lack of documentation. Gosh, people, sometimes we just don't do the right documentation, or we get tired of writing, or we want to just, I'm kind of done with today. And so when you're done with today, sometimes you just want to take that shortcut and not document it appropriately. Or there's one last sentence you should have put in there. Or you didn't use AI to put in the right words that are there. Whatever it may be, you need to make sure you're documenting everything, because what they do is when they audit, they go back and look at the documentation. Did the documentation that's there support what they built? And again, it's not like they pay all this money for sleep studies, right? Normally you think they go, right, in healthcare, things go up and up and up. In the sleep industry, has that happened? No, it goes down and down. And so, okay, you got to stop somewhere, because, you all work not for fun, but for money. You might work for fun, but you like to get paid for it too. So you want to take a look at everything you're doing inside your structure. Also take a look at credentialing and licensing violations. This is a huge one. I'm going to show you in a minute what they found in some of their licensure, and some hospitals in the Northwest got fined. It was several hospital systems right before COVID, $120 million they had to pay back because they couldn't show the proper documentation on the sleep studies of who was doing them. So if you have any credentials, well, we all have credentials, but when you have credentials, make sure you're putting them every time behind your name, and you prove it ongoingly, because that little mistake costs them that along with non-accreditation, and we'll talk about that in a minute. And feel free to ask any questions along the way. Number one, that lets me know you're still awake, but which is always important to me. But number two is sometimes it just hits you and say, well, what about this? And we're here to learn. That's what we're all here for at every one of these lectures. Non-compliance with accreditation standards. Now you'll notice in here accreditation standards that are set forth, they're by an accreditor. We're going to talk a little bit about that. We're going to talk a little bit who sets those standards. It's interesting, the OIG, they do recognize AASM, as everybody knows AASM, but in their reports they mention ACHC and the Joint Commission because it's on a different cycle. They're 3-year accreditations. I'm ACHC, it's a 3-year accreditation. AASM is a 5-year accreditation, and they look at a little different stuff than what is required sometimes with the LCDs, and we'll talk a little bit about it. There's no negative or positives there, but I'm just letting you know that's part of what the OIG said in their summary. Medical necessity and overutilization. OIG audits may find sleep studies performed on patients without evidence of medical necessity. I don't see that happening. We do audits all the time. I almost never see that happen anymore. But if you're going through the accreditation, that is your kind of buffer, right? I mean, accreditation should be a buffer of what's going on. But OIG is still seeing it. But you know what? Not every place in the U.S. requires accreditation. So that's interesting. So accreditation is actually, and whether you do or not, it's a very inexpensive way overall to make sure you're monitoring exactly what needs to be done. Now, most everybody here, I don't know where you're all from, I want to say between the Southeast, but the Northeast, and we'll go through it in a minute, none of the Northeast requires accreditation. And we'll talk about that too. Non-adherence to program requirements. So everything is outlined in the Medicare or Medicaid or even a private payer's regulations. Okay? So non-adherence, now private payers, Medicare doesn't care about. But private payers, they just recoup the money and don't send you to jail and put you in a nice orange suit. Medicare, they don't usually send you to jail, they just fine you a whole bunch of money. Although we did have one in Texas go to jail for 22 years for fraud and abuse, and I don't even have it in the presentation. What was it for? They used people off the street to do the studies. They weren't trained, there was no documentation of it. Now that happened about 7 years ago, but nonetheless, and what happened to the program? They fined them $22 million. Okay? The owner of it did go to jail. Did they ever pay back the $22 million? No, they declared bankruptcy and there they go. So, and we all know what's the adequacy of those tests, right? They also happen to be the companies, and I'm not saying yes or no to this, they also sold every one of them, can't say every one of them because I didn't audit it, but almost every one of them got a CPAP machine to go. Imagine that. And let's face it, CPAP machines, you really have to have OSA to really enjoy wearing one. I mean, you do, people do, and they carry them with them. But it's something you have to get used to. It's not something you just want. And your spouse wants it because they want you to shut up. But that's a totally different issue. Potential consequences of sleep facilities, recoupment of overpayment. Facilities may have to return payments to Medicare or Medicaid. May have to return. Yeah, they're going to return it. There's no may to it because what they do is they recoup future payments. So when you bill again, they just keep the money. It's kind of like giving your kids a credit card. It never comes back to you. Fines and penalties, we've talked about that for noncompliance. And what is really cool is what they really do when they really show you the love is they make you to be excluded from the Medicare program. One of the things we see, and one of the things in your sleep labs, you make sure that every time you do hire somebody or go through it, that you do what they call an OIG check. If you do an OIG, if you're not doing an OIG check, and we started first doing accreditations, we found a lot of labs were not doing OIG checks. You can go on and just search for your name just to see. If it's on there, then run. Move to Costa Rica or something. But anyway, OIG check, what it does is if you're on that, your company is subject to $10,000 fine per violation. It means that Medicare has said you're a risk to the Medicare, you can't play in the Medicare program, and so you're on this exclusion list. Now, it does take a little bit to get on that list, but it is there. You need to check it. You need to check your employees for it. Some do it monthly, some do it once a year. You usually know if they're having trouble with it. But anyway, and there's no charge to it. You just go online to the OIG, and there's an exclusion list, and you can go and check it. To get more specific information about the OIG work plan, most of you are going to get this. This is a website. You can go to it. Every year they come out with a new work plan. It's good to take a look at it to see if there's anything that is on there that involves sleep. And that is a good audit for yourself or your lab to do. If it's on there, because I'm telling you it's coming if it's on there. So this is, I've already gone over this. I'm not going to go. This talked about University of Michigan. There were several of them in this. But what they did was, the amount doesn't look like much, like $3,000, not a big deal. But what they do is, it's kind of, they use it as a threshold. Well, they did $3,000, but then they compound it and say, well, if you only did 30 studies, but if they did 90 studies, this is how, and that's why it ended up being in the millions. So you need to take a look, because they are finding labs for either non-credentialed or not the right person reading the study, outlined by the LCD. Okay, a validation or accreditation. When it comes to healthcare, accreditation refers to the official review process that allows organizations to demonstrate their ability to work regulatory and to make sure they are following all your rules you need to do and delivering the best care. What happens with accreditation? All we are is, all the accreditation, we're becoming the eyes and ears of a payer. I always say, when you're doing audits, follow the money. When you're doing a study, follow the money. If you want to find anything going on, follow the money. Where does it go? And every time, it will lead you to, hey, this is the problem. What's going on? So it's very important to any organization to have a process in place. That's what accreditation does. And you should never, ever, never be scared of accreditation or validation. Why? Because it only protects you. Sometimes people get upset maybe because the surveyor maybe have an attitude. Not saying I would ever have an attitude. My kids would say differently. But nonetheless, but you know what? At the end of the day, I hope a surveyor is never there to say, hey, I'm smarter than you and this is what needs to be done. If they are, just grin and bear it. And in our case, call me. But the point is, they're there to be the eyes and ears really of a payer. Because if you're not accredited, you can't get paid in most instances. But there are exceptions. Okay, we're going to talk about NCDs and LCDs. And after lunch, man, this can put you to sleep even more. But I want everybody to walk away knowing these definitions. An NCD is National Coverage Determination. An NCD sets forth the extent to which Medicare will cover specific services, procedures, or technologies on a national basis. Medicare contractors are required to follow NCDs. If an NCD does not specifically exclude or limit an indication or circumstance, or if the item or service is not mentioned in all the LCD or in a Medicare manual, it is up to the Medicare contractor to come up with it. Now I'm going to put you all on the spot here. Are there NCDs for sleep testing for Medicare? They are not. Right? That's what I said, right? Well, I've done this a long time. Because look at number 2 is. Now, remember, they're NCDs for CPAPs, right? They're NCDs for the equipment you can, they can write a script for and they go home to treat it, dental implant, whatever it may be. They're national coverage. But what happens in sleep is every one of them are controlled by the LCD. That's the contractor. LCDs are local coverage determination, are policies developed and published by a Medicare administrative contractor. So therefore, I am going to contract with myself, or I'm going to contract with a guy named Stuart. And Stuart is going to say, okay, I want to limit to make sure everything is being followed, so I'm going to make up the regulations for this, for the coverage of a sleep study. Now, you would think they'd all be the same, right? Wrong, because they're done by your local contractor that is in there. You're not done by the NCD, so Medicare doesn't have it. Medicare has it for CPAPs, for dental devices. They have it for Inspirant. Well, they don't pay for that, but anyway, they have it for certain things, but they don't have it for sleep testing. They leave that to your local contractor. So what does that mean? You have 2 contractors that are in there, and they're Medicare acronyms. You have the MACs, which are administrative contractor, private health care insurer that has been awarded a geographic jurisdiction for a Medicare Part A or B, meaning in the state of Tennessee, this is who's going to oversee Medicare and my sleep testing, okay? Well, I don't know where you live, but we'll go with yes. So here, yes. So, well, I'm going to show you that. I got it all, and that's what I'm saying. Get a hold of this because this goes through all their regulations. Decisions made by a MAC, whether it's covered, are enforced by the LCD, not by Medicare, although it is Medicare, right? But it's the local provider that's covering it. Now, you'd think all the rules would be the same, right? Well, look at this. So, Tennessee's Palmetto, Alabama, Georgia, North Carolina, South Carolina, Tennessee, Virginia, West Virginia. Palmetto writes the LCD. If you want to know what the rule is for the LCD, you know, you go to this number, pull up LCD, Google it, Yahoo it, American Online it, DuckDuckGo, all these other web. Well, I got in trouble one time because I just said Google it, and that's kind of, so I guess there was somebody employed by Google that was in the audience. Anyway, but if you go to that and pull up LCD and this number, it's going to tell you all the rules you need to follow. And just when you think you know all the rules, and go on it, they can change them. So it's important to note that now, us as an accreditor, we're always going to keep you informed, and I'm not just speaking, there are other reasons not to use us, and there are reasons to use it, but you need to do more than just pay a fee. You need to be aware of the regulations that actually, and you'll get notices from the LCDs, but sometimes you get so many of them, they end up and you probably shouldn't do that. So, and if you look at all of these, now look down here, in the NGS, which is National Government Services, none of these states have anything to do, although sometimes they're moving states around a little bit. This was done 1.5 years ago. But none of those states have any regulations for sleep testing. So does that say move to those states? Maybe. But nonetheless, they don't have regulations. Because it's all done, controlled by this. Now, we've heard they're coming out with them that's here, and that will boost the accreditation. Because what do they, all these have accreditation components. And it's really ACHC, the Joint Commission, or AASM. that they all accept. Let's get it complicated just a little bit more. And I have no idea how I'm on time, but anyway. Y'all having so much fun that you don't care. Okay. So let's talk about the technician credentials, okay, that are there. They vary by LCD. So let's just have some more fun just figuring this out. So you can go through them and read it, but I'll make it easier. If you go over here to the differences, well, 405 and 593 includes the credentials CRT, SDS, RRT, SDS, registered, and includes obviously a registered polysom is in there as well. But one excludes the credentials of what's listed below. Some, though, will allow a respiratory therapist to do it. A registered polysom is always there, but some don't allow a respiratory therapist to do it unless they have the SDS credential. So what happened in some hospitals? This was a kicker. Some hospitals actually missed this regulation. 2 years later it came out. They did an audit and they found out their respiratory therapists didn't have their SDS, so they went and they asked for a recoupment of the money because they didn't have the right credentials doing it. So it's so important to keep up with exactly, and it's always in the state that you're billing from. Even though the patient could come from another state, it's in the state you're billing from. So these are very important to do. Now let's get a little bit more complicated. I know you're taking a picture of the screen, but I know I'm in it, so hey, it's something to remember me by. So interpreting physicians, do you know they're listed in there as well? Some LCDs actually talk about who does it, who can do it, who can't do it. So that's what happened in Michigan as well too. They had some interpreting physicians that weren't boarded in sleep doing it. They were a medical director, but they weren't boarded in sleep. They did the interpretation. So the LCD went, and the LCD and the insurance provider went and got the money back from them, recoupment, because the wrong person did the interpretation. And if you notice in here, some do ABS and fellowship. You know, you can have a fellowship through it. Others do not do a fellowship. You have to be boarded in sleep. So make sure you read the LCD. Now, North Carolina Palmetto, they will allow for a fellowship. But in some of them, they don't allow for a fellowship. They have to be boarded in sleep, or they could be subject to a recoupment. When I say subject, that just means if they catch it. Okay, now let's talk about Medicare for a minute. Because, again, a lot of sleep studies don't have anything to do with Medicare, but a lot do, right? So we heard all this, and if you have insomnia and you're up at night and you're listening to all the Medicare ads, and they're talking about, join us today, the Medicare Advantage plan. Sign up today. Well, I've been working with this for about 10 years, and I even got more knowledgeable of it when I turned 65. Okay, that was your point to say you don't look it, but you didn't do that. That was your shot, but we're going to move on from that. I feel sad now, but anyway, so you have Part A and Part B. That's what we call traditional Medicare. Part A and Part B. Part D we're not going to talk about at all, because Part D is about the medication. But it's easy. If you ever want to go on Medicare, not if you ever want to go on Medicare, when you get old enough to go on Medicare, you can do a search. It's really easy to find out if your medications you're on are covered by a Part D plan. Medicare Part C, the Medicare Advantage. Okay, every time you talk to somebody, so I've already seen heads shake on it. I'm not going to tell you what to do, what not to do. But right now, Medicare Advantage plans are supposed to have the same rules as regular traditional Medicare. but they're not controlled by an LCD, so they don't. So when your lab gets a Medicare Advantage plan, make sure you have a contractor like United Healthcare or Humana or any of the other 365 of them that are out there, and make sure they're going to pay for that sleep study, because it may not be paid for under Medicare Part C, which is a real challenge. So, and just because this is so passionate for me, Medicare Part C, if y'all go to my website, if you go to achcu.com. Write down, it's good. It's good stuff here. achcu.com. And go under webinars under DME. Go to the webinars and look at the one that David Chandler did from AA Home Care about Medicare Advantage plans. Then make your decision. But I think the issue becomes is Medicare Advantage plans used to be, 4 years ago, they were 20% of everybody that signed up for Medicare. Now they're over 50%. Why? Because Medicare Advantage plans, not only do they make money by saving money by not paying bills, maybe, they also make money because they get paid from Medicare, because now Medicare doesn't have to administer them. So it's a win-win for Medicare. Because now I have less people enroll, because Medicare doesn't administer it. The Medicare Part C, the insurance provider does everything for it. Medicare doesn't administer it. So it grows, because if you are 100% healthy, you have no aches and pains at all, and you don't have to worry about paying a great deductible. It could be free, right? But if you get sick, that's not so much the case. And if any of y'all, everybody's shaking your head, evidently you've dealt with it before. But go in and take a look at that on our website, and you can go through and look under DME and look under sleep, and look at all those webinars are free. You can look at them, and they're really good in detail and talk about different programs that we have. That's just part of services that we do for everybody. I can always talk a long time about that, but the reason I mentioned it is because those are labs that go through it, and they said, well, you have managed care plan. Well, make sure you're getting the right authorization that is done for that beforehand. Sleep testing over the past few years, during COVID, we had over 200 labs closed, which you probably know about when they started coming back. Now we're back up about to where we were, not quite with the labs, but everything's transitioned to let's screen it. Advantage plans are traditional. Let's screen it first with home sleep testing, because you heard them talk about earlier, and I think Robert Miller was talking about it, about all the technology in home sleep testing. It's getting better and better. That's there. So, but nonetheless, there's nothing like an in-hospital study. You don't have to worry about your job or anything. There's nothing concerning about that. But they are doing more and more screening with it and paying for simple OSAs without comorbidities. Home sleep studies working fine. So in order to, where is my phone? How much time do I have? Anybody know? 20 minutes. 20 minutes. Oh. And y'all wanted to get out early. Ha! Okay. You go, yeah. Okay, we're going to speed this up. Put a little disco music. We can okay. Well, we'll go through this order. So in this presentation, we're going to talk about sleep monitoring. What is normally done? What does an accreditation company do? What does the payer do? Because payer, besides all those LCDs, they make sure that they are having all of the monitoring equipment that needs to be there. So let's just go. I'm just going to go through it quickly to talk about it. Licenses, organization reflects the organization chart that's there. Copy of fair labor, a resume application of not only the leader but every employee, right? Make sure they have the right credentials that's there. Access to all laws, temporary leader, marketing materials, complaints. I want to do a special thing on complaints. Here's why. Because one of the things they're doing is, if you test a person and they don't like what you did, they don't like your interaction, whatever it may be, if they complain to a payer, then you need to have all the proper documentation. When the OIG comes in to do a study, well, OIG tells CMS to do it, and then if it's real bad, the FBI comes in. Just know if they have FBI, it's probably not a good day for you. just saying that. Just saying that. I got a call one time. I'll never forget it. They said, Tim, the FBI's here. Going, click. No, I didn't do that. But I'm going, but the thing is, there's nothing we can do at that point. And they're there for a reason, and you can bet if they're there, something's happening. But it's probably not your doings. It's probably, in the paperwork or what's going on. But the most important thing to do in that, besides billing correct codes and having the right people, is document every single complaint. You need to decide what a complaint is. And that's really important. Here's what I mean. If they're complaining because the bed was too firm, if that's something that you need to know, that's not really important. It's important because they might not come back or recommend you. But if they're complaining because the lead came off 15 times, nobody got back with them, it took me forever to schedule, and then they never called me back. If they're doing that one, that's really causing an issue with maybe their care. That's something you need to address. So keep that in mind. Make sure it's well documented of what you've done to correct it, and the patient's name and identifying information. Because that's the first thing they're going to look for. Well, if you don't have a complaint log, how do you know? Do you just do a study and leave? I'm assuming most of y'all weren't around the day the OBGYN was doing the sleep interpretations. But, that happened in the past because this was a way to get reimbursed. We don't have that anymore because the regulations are getting tighter. But that all comes to it. There might be OUSOB. But anyway, I meant to say MOUSC, but it didn't come out that way. But anyway, but they might be boarded in sleep. That's a different story. But what I'm saying is make sure that anything that's documented, anything that comes in, but define what a complaint is. Okay, insurance, personnel policies. Make sure you have a personnel file on every single person, and it's documented exactly what their credentials are. Now, we ask for other stuff too that's very important to have. Nothing's more important about documentation of their credentials, and they're up to date in that personnel file. Qualified medical director. Now, every creditor has something different. The LCDs don't say anything about who needs to be the medical director. Like small hospitals, they don't have it. But they're very specific about who can interpret a sleep study. And so sometimes in small rural hospitals, you don't have a boarded physician that's there, but you have a physician that can be the medical director. LCDs don't mention anything about that. But they do mention who can interpret the sleep study. Ongoing PI records to just make sure your equipment's working, what's going on, the maintenance of the record that's there. We won't go into these in great detail because, again, 20 minutes, got to go. Make sure you are cleaning and you show documentation of your cleaning of equipment. Because you don't want that person that had MRSA to come in there and somebody else, the next person got MRSA and the next person got MRSA, and you don't think that'll happen. It does happen. It can happen. It has happened. Make sure you are cleaning it properly. You have a cleaning procedure, and when anybody walks in there, everybody knows the same cleaning procedure. And you think, well, that's pretty good, and everybody understand that? I'm amazed at the people when we go into their lab, they don't understand. Everybody needs to know and do it the same way. sleep trends, we're going to end up here. You need to adapt to change, obviously, that's there. You've heard that all day long of what you're doing with your lab. But it's so important to make sure that when you adapt to change and adapt to the market, and the market is actually changing as we know, then you need to adapt to it, whether you're increasing, whether you're contracting your home sleep studies, whether you're doing your own home sleep studies, whatever you're doing. But it's probably part of all the private payers' criteria these days. Contracted entities. I just want to talk just 1 second on this one real quick. If you're at a small hospital or if you're contracted to do the entity, the accreditation, so I go to a critical access hospital or a 50-bed hospital or a 100-bed hospital. They don't have their own sleep lab, but they're in rural Iowa, and they need this for the community. They contract out their sleep system. That's okay. But remember, the hospital is the one getting accredited. It's not the entity. They can do all the documentation, but the hospital is who owns that accreditation because they're the ones that want to have it. But contracted facilities do well. I mean, we have a lot of, because that's the way rural America works of what's going on with it. Hey, I only do 2 studies a month, but I want to be able to do it because otherwise the community has to drive 3 hours. And in Alaska and Iowa, I can assure you it happens. In Dakota, because anybody been to Langdon, Dakota? Yeah. I flew, then I drove 3 hours, then walked into the hospital. It was 7 beds. Yeah. And 2 of them were it's the sleep lab. 2 of them were the sleep lab on Wednesdays of every other week. But you know what? That was the closest thing to them. The other closest was 2 hours away in Canada. So you don't think about this if you don't live in that environment. But it's out there, and it's really interesting to go out there. The nice thing about being a surveyor in sleep or DME is you get to see what everybody else lives through that we take for granted. But, you know, I couldn't find a beer there. But anyway, not that was that important. So sleep accreditation, what I did was we put together, this came from the Sleep magazine about the different prices, what they do, because there are different offers. Most of you are familiar with us. I've been here for several years, the Joint Commission or AASM, but there is a breakdown of exactly what's going on with it. It's out there. It's in Sleep Review. You can go through it. And as I end up here, my name is Tim Safley. Again, don't hesitate at all to email me on any questions you have about LCDs, NCDs, what's going on, if you want me to send them out there. But it's a good idea to keep a look at the numbers of those LCDs because that's what keeps you informed. So as I end up a little early, are there any questions? Right, this means off the stage so we can go. I get this. I speak your language. It's okay. I've been there. Hey, guys, thanks a lot. It was a lot of fun.